Hello everyone and welcome back once again to Pediatric Pearls. I'm Dr. Sonia Jamaal and today's episode is a special follow-up to our hugely popular discussion on severe functional abdominal pain in children. In our last episode on functional abdominal pain in children, we had discussed this topic in detail. However, since that episode aired, many of you sent us your stories and some tough, heartfelt questions. So I've invited Dr. Kazmi back once again to help us tackle them together. Dr. Kazmi, welcome back.
Thank you, Dr. Sonia. It's great to be back, and I'm glad we are doing this. These are the cases that keep families up at night, and they keep us up too. So let's dig deeper.
Absolutely. Let's jump right in with one of the most common queries we received. A mother wrote to us about her 13-year-old daughter. The girl has had mostly right-sided abdominal pain for years. She already had her appendix removed a year ago, but the pain still comes and goes in the right iliac fossa. She's missing school, paracetamol doesn't help, and the primary care practitioner wants another ultrasound, but the pediatricians are saying it's not needed. The mother is worried nothing is working. Dr. Kazmi, what would you say to her?
First, I really feel for this mother and her daughter. This is exactly the scenario we talked about. And in practice, we see so many of these cases where so much has been done without any real relief. When pain persists after an appendectomy and all other scans and blood tests have been normal, we must think about functional pain as the most likely cause. Now, in these children, the problem is not another hidden organ disease. It's how the brain and the gut are miscommunicating pain signals. And the public as well as practitioners, they must remember doing repeat ultrasounds again and again rarely changes anything, especially if there are no new red flags like fever, weight loss, blood in stools, or worrying exam findings. Here, repeating scans only fuels anxiety and adds further to the problem.
So what should this mother do instead?
Good question. This is where we shift focus from finding a cause to managing the pain properly. So step 1, sit down with your pediatrician and ask for a clear explanation of what is functional abdominal pain. Step number 2, ask about starting a neuromodulator medication, like for example low-dose amitriptyline. It works better for this nerve type pain than paracetamol or ibuprofen. Step 3, if the school absence is severe, get support from a pediatric psychologist for cognitive behavioral therapy. And step 4, make a plan for normalizing life. School attendance is vital in these cases even if the pain is there. Pain clinics or specialist pediatric gastroenterology teams can help if local pediatricians they feel unsure.
That's so practical. And I imagine the same ideas help with another listener's story. She wrote about her 6-year-old child with off and on abdominal pain. No cause has been found. She was treated for possible constipation with Movicol, but the pain came back once the stooling got better. What do you say to parents in that situation?
This is another classic. Many kids have overlapping functional pain and mild constipation. Clearing constipation is always step 1, but when the pain persists, despite soft regular stools, the likely culprit is again visceral hypersensitivity because the gut is overreacting to normal sensations. Now these children, they need reassurance. They need good gut health routines, and if the pain is frequent or disabling, then the same approach, and that same approach is number 1, you rule out red flags. Number 2, you avoid repeat tests if the workup is reasonable. Number 3, you use neuromodulator medications if needed. And number 4, you add cognitive behavioral therapy or relaxation therapy as they really do work. And remember, always avoid opioids or repeated antibiotics because they won't help here and they can simply make things even worse.
So families shouldn't feel guilty if the pain keeps coming back.
Absolutely not. Now, this pain is real. It's not in the child's head in a dismissive sense. It's the gut-brain axis misfiring. So parents, they need to know that they didn't do anything wrong. And these children can and do get better. But the plan must target how the gut and brain, they talk to each other, not just simply chasing normal scans.
Before we wrap up, any final take-home for parents and GPs who face these situations over and over?
Yes, 3 golden rules. Number 1, always trust your workup. If the child is growing, the child is thriving and has got no red flags, believe the normal test. Number 2, don't chase the pain with endless scans and painkillers. Rather, switch to a gut-brain approach. Number 3, seek help early. A pediatric pain team, a psychologist, or an experienced pediatrician can help map out the right medication and therapy plan. And above all, children can live normal, happy lives again. Families, they need hope and a very clear plan.
Got it. What about medications beyond low-dose amitriptyline? What's the next tier?
So here's a practical pharmacology ladder for clinicians. Number 1, tricyclic antidepressants. Now again, they are not antidepressant in this particular sense when we are using it for functional abdominal pain. Here, amitriptyline is the first line for older kids, I would say like 8 years and plus, despite the fact that the use is still off-label, but there is a lot of evidence that it works in this condition. If it fails, or let's say side effects happen, then you can try imipramine or nortriptyline as alternative medications of the same class. But one has to be cautious with ECG to rule out any QT prolongation, as we already discussed in the first episode, and also sometimes anticholinergic side effects like dry mouth and urinary retention, etc. Number 2, SSRIs. For kids with clear anxiety, panic or depression associated with functional pain, an SSRI like sertraline or fluoxetine can help. One has to start low, for example, sertraline in a dose of 12.5 to 25 mg daily. Number 3 is cyproheptadine. Now this drug is handy in younger kids with upper abdominal pain or dyspepsia or sometimes even encyclical vomiting syndrome. It works as an appetite stimulant too, so it's useful for thin, anxious kids. The dose of cyproheptadine is around roughly, I would say, 0.25 mg per kilogram body weight given at night, and do expect some sedative side effects. Number 4 is gabapentin or pregabalin. For older children or teens with severe neuropathic like pain and sleep disturbance, gabapentin can be used off-label in older children, starting as low as let's say 5 to 10 mg per kilogram body weight per day. You use it in divided doses. Now, pregabalin is more or less similar to gabapentin, but is less commonly used in kids. And number 5 is buspirone. Now, buspirone is used for functional dyspepsia with bloating. Sometimes low-dose buspirone can also help relax gastric accommodation. So it's a bit more experimental as research is still going on, but I thought it's worth mentioning that sometimes it can be of help.
Thank you, Dr. Kazmi. So much wisdom and so many practical steps. To our listeners, if your child has been struggling like these cases, please share this episode with your pediatrician, your GP, or your school nurse. This was Pediatric Pearls. I'm Dr. Sonia Jamaal. See you next time, and don't forget to send us more of your questions. Goodbye.